Good day, good afternoon, everyone, and thank you for joining us today. My name is Michael Poindexter. I have the privilege of serving as the board chair of the American Heart Association, now in my second year on the board for the last 7 years, and I want to take a moment to welcome you here today. In addition to serving as board chair, I also work at the Regional Food Bank as the Chief Program Officer and Senior Pastor of the Macedonia Baptist Church. And as always, we say thank you for joining us today and joining us through the many events and webinars that we have through the year. By participating in the Blood Pressure Awareness Challenge, you should know that you are directly impacting the health and well-being of everyone in your community, for you are raising awareness about a leading risk factor for heart disease that causes unnecessary and inequitable disease and death. Imagine living with something that could kill you or your loved one, and neither one of you have any idea about it. That's the troubling reality of uncontrolled blood pressure. It is a silent killer that causes unnecessary death and disease within our communities. Equally worrisome is that high blood pressure disproportionately impacts some people more than others. For example, the prevalence among Black Americans in the US is higher than any other racial or ethnic group. This condition robs people of time with their loved ones, and we don't want to have to waste any time. And so high blood pressure, it is largely treatable, but we can't do this alone. During this presentation, you will learn about several things. One, why the American Heart Association is focused on blood pressure, what the numbers mean, and how you can manage risk factors for high blood pressure, and the specific actions that you can take as a volunteer for the American Heart Association to help address this issue. At the end of the presentation, we will answer any questions in the chat and any questions that you may have. So with the chat, let's get started with a quick question to kick us off and get all things going. Do you know someone who has been diagnosed with blood pressure? Just write it in the chat, yes or no. Do you know someone who's has been diagnosed with high blood pressure? It could be a family member, a friend. It could be someone who goes to your church, someone who you go jogging with, someone who you work with. Just please write that in the chat. As we can see the chat flooding in. So many yeses coming through in the chat because it is actually very prevalent within our community. Please keep those chats going. Do you know someone who has been diagnosed with high blood pressure? So as we can see by indication in the chat, most of you, many of you, know someone who has been in fact diagnosed with high blood pressure, but it is incredible when you learn of how you can actually treat high blood pressure and how many people around you had it and you didn't even know about it. Did you know that nearly 1 in 2 adults in the United States have high blood pressure, yet less than half of them have ever been diagnosed? Did you also know that high blood pressure, only 44% of the people who have it under control? Did you know that blood pressure control rates were improving from 2000 to 2010, but since then have been declining? All of this despite easier access to the many different genetic medications to treat hypertension. Did you also know that high blood pressure is an epidemic for our community, but it impacts disproportionately some communities more than others? So let's take another quick poll. As you can see, we're going to have you active today. Get that blood pressure moving, but keep it under control. True or false? Here's a pop quiz. Is it easy to spot someone with high blood pressure? Write that. Do you think it's true? Do you think it's false? Is it easy to spot someone with high blood pressure? Start writing that in the chat. If I could, I'd write it in the chat. It'd be unfair because I'm on the Heart Association board, so I know the correct answer. But please, is it easy? You're out and about, you're walking, you're talking with someone in your office. Is it easy just through conversation, just by looking at them? Is it easy to spot someone with high blood pressure? For those of you who said false, you are indeed correct. It is not easy to tell if someone has high blood pressure just by looking at them. It's not even easy to tell when you have high blood pressure yourself. So it's important that you have to measure your blood pressure and that you are aware of high blood pressure and the prevalency within our communities. And with that, I am not a medical doctor, but I have someone who today can give us all of the ins and outs of high blood pressure, hypertension, all of the information that we need so that we can be the most effective community members as we can. I'd like to please allow you to welcome in Dr. Coplin of CDPHP, who's going to share some great information and tips around blood pressure. Welcome, Dr. Coplin.
Hi, thank you for the opportunity to speak with everybody. I'm currently the Chief Medical Officer at CDPHP, but in fact, that's a recent job. I've only been on the insurance side for a few years, and I was actually a practicing cardiologist for 33 years prior to coming over to CDPHP. So this is a subject that's near and dear to my heart. It's also an opportune time, and this was not intentional, but the way it worked out, the guidelines for blood pressure just actually changed about 3 or 4 months ago. The last time the guidelines came out was 2017. So these are new guidelines, as they say, over the last 8 years. And a couple of things that Mr. Poindexter pointed out that are still bothersome to me is how many people still don't know they have high blood pressure. And that hasn't changed over all these years. Part of that is people don't seek medical care. We had the highest score for patient and member satisfaction in the country for an insurance company. And yet 25-30% of our members still don't see a primary care doctor. People, when they find their pressures elevated, they tend to ignore it because it doesn't make you feel bad. It doesn't make you feel bad till it's too late. But it's frustrating that we haven't made more progress. And part of this, it's everybody's responsibility on this call. If they know somebody that hasn't been checked, or they know somebody that's been checked and isn't doing something about it, if they're not compliant with their medication, we can all help bend this curve a little bit because it is frustrating. And of all the things in healthcare that are potentially preventable, the consequences of high blood pressure are near the top of that list. And so again, I'm anxious to go over this with you in some detail. So what is blood pressure? We need a blood pressure to force the oxygenated blood from the left side of the heart. It pushes it around the body to the various organs, to the muscles. The oxygen gets used up, and then it comes back to the right side of the heart via veins. The veins dump into the right side of the heart. The right side of the heart pumps the blood to the lungs. The lungs reoxygenate the blood, and it starts the entire thing again. But it is a loop. Let's talk about what the actual numbers mean. So the upper number is what we call the systolic number. So when the left side of the heart pumps, that's the maximum pressure the heart generates to force the blood out to the body. And so that upper number, when the heart contracts, that's what we call systole. And so that's referred to as the systolic pressure. When the heart relaxes to take blood back into the chamber for the next beat, that's called diastole, and the lower number is called the diastolic pressure. So when we talk about the pressure, the upper number is the systolic and the lower number is the diastolic, and we always talk about them together with the systolic on top and the diastolic on the bottom. We also talk about mean blood pressure, and I'm not going to get into the equation with you, but I do want to correct some misconceptions. One is that as you get older, it's okay to have high blood pressure. And we'll talk about what happens as you get older, and people do get a much higher incidence of high blood pressure. But for years, people were under the impression that, if somebody was in their 60s or 70s, a much higher pressure was okay. That's not true. And one of the things that have really changed in the new guidelines is more aggressive management of the pressure. And we want everybody less than 130 over 80, which we'll talk about again in a little while. And there were a lot of misconceptions. It was the upper number that was more important, and then it was the lower number that's more important. They're both equally important. And in fact, if you look at the mean blood pressure formula, it's actually gives more credit to the diastolic pressure, to the lower pressure, because if you look at the cardiac cycle, systolic compression versus diastolic relaxation, 2/3 of that cycle is actually in diastole. So the lower number is still very important. What about, next slide. High blood pressure, again, is a silent killer. And it's really important to understand that. You will not feel bad with hypertension. And as your blood pressure keeps going up over the years, the body makes some adjustments, thicker vessels, and other less distensible vessels. It kind of starts adapting to that. So again, you don't tend to feel anything until it is too late. And again, what you worry about is stroke, heart attack, renal failure, heart failure. And again, we'll talk more about that. If you look at why do people get harm with high blood pressure, what actually happens? Well, there's a bunch of things that happen. One is that because the heart has to pump this higher pressure all the time, the walls of the heart start getting thicker and they become less distensible. The heart does not relax properly because there's really thick heart walls. And as a result, the pressures in the heart start going up. And as I mentioned, that's a loop with the right side of the heart. Those pressures start getting backed up into the lungs. When the pressures in the lungs start going up, fluid starts leaking out into the lungs, and you can get heart failure. There's also the vessels themselves start getting thicker walls, and the vessels become less distensible, less compliant. And again, that results in further pressure. Also, over time, that shearing force, so that systolic pressure, when it pumps against the vessels, creates a shearing force against the inner layer of the arteries, and especially the large arteries. And you get micro tears that tend to be filled with cholesterol plaque. And that plaque buildup over time is what we call atherosclerosis. And that becomes very problematic in that if those plaques rupture, you actually get a clot. And it's that clot that can cause strokes because the vessel gets closed off, heart attacks, and again, a lot of the consequences that we have from high blood pressure. Similarly, if you look at renal failure, again, what happens is there's less blood supply to the kidneys. The kidneys themselves become damaged. They become less efficient at extracting toxins. And so you start developing renal failure over time, again, due to these vascular changes from ongoing long-standing hypertension. And same with peripheral artery disease. You probably all know somebody that's had bad peripheral artery disease, resulting in amputations at end-stage disease, which again are preventable if we can get involved earlier on and be more aggressive in treatment. Same with heart attacks. Again, those plaques in the coronary arteries, the arteries that supply blood to the heart, those rupture and again can cause heart attacks. We spoke about heart failure from the heart walls becoming thicker and the heart becoming less distensible and pressures going up. And stroke is, again, same thing. The American Heart Association now has created 5 ranges of blood pressure that are now recognized by the American Heart Association. The first is normal blood pressure, and that's a systolic, the upper number less than 120, and diastolic, the lower number less than 80. The next is elevated, 120 to 129 for systolic and less than 80 diastolic. Stage 1 hypertension, which is the true first stage of true hypertension, is 130 to 139 systolic and 80 to 89 diastolic. Stage 2 is 140 or higher for the systolic pressure, 90 or higher for the diastolic pressure. And then the last 2 are really just one category, but treated differently. Severe hypertension we define as a systolic pressure, sustained pressure, over 180 and a diastolic pressure less than 120. You can have severe hypertension that needs to be treated aggressively. And so I don't want to make you think it's not an urgent problem. It is. But if you're asymptomatic and have no evidence of significant end-stage disease, that doesn't necessarily have to be treated immediately with a call to 911. But if you have a pressure over 180 systolic or 120 diastolic, and you're having symptoms, whether that's chest pain, shortness of breath, stroke-like symptoms, change in vision, that's an emergency, that's a 911 call. And in that case, you'll end up being admitted to the hospital. And we refer to that as hypertensive crisis, hypertensive urgency, accelerated blood pressure. Again, it goes under a lot of different names. And again, back to the slide before this, having high blood pressure greater than 130 over 80 definitely puts you at risk. And again, you will have no symptoms at 130 over 80. And so that's really important to note. And another important point to note is that for every increase 20 millimeters in systolic pressure or 10 millimeters in diastolic pressure, for every increase of 20 over 10, your risk of heart disease doubles. Next slide. I just want to make one comment about white coat syndrome. It comes up a lot. A lot of people go to the doctor, their pressure's elevated. They say, oh, it's white coat syndrome. That's when pressures go up because of stress. And a lot of people find it very stressful to go to the doctor. Some people find it very stressful to check their blood pressure. A few points on that. Number one, it's not benign. We know statistically that if you truly have white coat syndrome, you have a much higher risk of developing sustained hypertension in the future, and usually not the distant future. Number two, home blood pressure monitoring is very helpful in that situation. There are some people that even when they monitor their pressure at home, they get so anxious, even their pressures at home go up. And I just want to mention that there is ambulatory blood pressure monitoring available. We put on a 24-hour blood pressure monitor, which is just a cuff you'll wear for 24 hours. It'll get multiple readings through the day and night and get a better idea of what your pressures are really running outside the office. So again, if a physician suggests that, or if your pressures are all over the place, it's a good place to start. One other point here is that if your pressures are over 160 over 100, that you should be promptly started on antihypertensives. One of the new points about the guideline, we were always stressing lifestyle modification to the point where people were doing it for years. They give you 3 to 6 months now, and if that's not helping, you need to be on medicine. Plus, if you're starting out this high, you need to be on medical therapy. Next slide. What puts you at risk? So part of it's hereditary, family history, and that can be fairly dramatic. A lot of families have histories of hypertension, even starting at young ages, and often those patients have refractory hypertension. Number two is age. We all develop higher risk of hypertension as we age. And in fact, if you take adults over 65, over half have hypertension. Gender, males tend to have hypertension at a younger age. Women catch up at 65 and actually pass men for hypertension at age 65. And interestingly, if you look at the incidence of heart attacks and coronary disease, the same is true. Women have a much lower incidence of heart attacks up to 65. At 65, they not only catch up to men, they surpass men. Mr. Poindexter talked about race. And again, if you look at African-American individuals, they do have a much higher incidence of hypertension and also more refractory hypertension that's more difficult to treat. And in fact, that group will often be treated with different drugs as a starter than other races. We tend to avoid ACE inhibitors and angiotensin receptor blockers in that group as a first-line drug, and instead tend to use more thiazide diuretics and calcium blockers in that group. Another thing that's going to be interesting about this, we treat everybody with hypertension kind of like it's the same. It's one disease. I think in the next 5 to 10 years, you're going to have different genetic etiologies for hypertension, and we'll have much more directed treatment directed at whatever that genetic anomaly is. And we'll be treating everybody as an individual and very differently than we're treating everybody now. And I think there will be some great new drugs coming out that can really address, specific genetic anomalies. Next slide. What factors are modifiable? Again, I would say that one is activity. And that's a big thing. And for me as well, I'm going to sit here and there's several of these that apply to me personally. We suggest aiming for 150 minutes of aerobic activity, a week. We also recommend 2 days of strength or resistance training per week. That's one where most of us fail. And again, most adults as they age lose muscle mass, and that's especially true in the upper extremities. And again, it's a good idea to do some resistance training, lightweight training, in addition to the aerobic. And again, the aerobic doesn't have to be going to the gym. It doesn't have to be working on fancy equipment. It can just be a moderate to brisk walk, 30 minutes at a time, 5 days a week. And that's been shown to make a very big difference. Diet, there's all different diets out there. There's the Mediterranean diet, which is everybody's heard of. There's the DASH diet that we'll talk about that the American Heart Association supports and is not that different. And most of these have a lot of similar components. I want to address two things. One is sodium intake. Americans consume a huge amount of sodium. For the healthy American, that's not on any, that has no major medical issues such as hypertension or cardiovascular disease, the maximum limit is recommended to be 1 teaspoon of salt a day, which is 2,300 milligrams of salt. That's still a lot of salt. Once you have heart failure, coronary artery disease, chronic kidney disease, it actually drops to 1,500 milligrams a day. I would personally suggest, even in healthy people, that it's a maximum of 2 grams or 2,000 milligrams a day. And you can look at the content of a serving on every single thing you eat. It'll give you the sodium content of one serving, usually in milligrams. And again, 1,000 milligrams is a gram. So a 2-gram diet would be 2,000 milligrams. Potassium is one that's often not talked about. Taking in more potassium actually helps you get rid of sodium. There's a sodium-potassium exchange, and it helps you urinate out more sodium. Also, potassium itself has some relaxation effect on the vessels. What foods are rich in potassium? Vegetables like potatoes, but potatoes with the skin, sweet potatoes, spinach, beet greens, fruits, especially bananas, are great. Avocados are great. Apricots, dried apricots, cantaloupe, beans, legumes, and also dairy, especially milk and yogurt. Obesity. Obesity is a real problem in the country. It's increasing. One of my major things is childhood obesity. I wish we would make bigger strides in childhood obesity. We always talk about our healthcare system. We actually have a sick care system. We're great at taking care of sick people. If you're really sick, you want to be here. Healthcare, we're not so good on. If you look at maternal mortality, infant mortality, obesity, smoking, control of hypertension, we're way down the list, and we need to do better as a society and truly be addressing healthcare. And obesity is a problem actually increasing worldwide, but especially in this country. We often look at what we call the BMI, which is the body mass index. And again, I won't get into the formula. Your doctor will tell you what your BMI is based on your height and your weight. For years, I was hoping I could get taller instead of trying to lose weight, but that's not going to happen. The other thing that's difficult with weight is that if somebody's way overweight, they're trying to get, in their mind, they're trying to get down to like a closer to a normal body weight. And they say, it's undoable. I can't do this. And it becomes overwhelming. You only need to lose 5% of your body weight to have a significant benefit in terms of your blood pressure and your longevity. And so people need to be realistic about what's attainable and not get discouraged when they don't lose more than they want. Alcohol, again, there's some literature suggesting that a drink a day for men and two drinks a day for men and a drink a day for women is okay. It's not. There's no benefit of alcohol to speak of. It's actually a toxin for the heart. People that drink a lot have a much higher incidence of arrhythmia. It can increase your blood pressure, increase, again, they're empty calories, so it contributes to obesity. And again, current guidelines do not advocate alcohol. Sleep apnea is a big one. Again, a lot of people have sleep apnea. It's probably one of the most undiagnosed problems out there. And again, just being confident, just talking about my own situation, I just had a sleep study actually done on Friday. And you can do them at home. They're incredibly easy to do. They send you stuff at the house. You just put it on. They show you how to do it. It's super easy. And if there's any question at all, sleep apnea leads to a lot of problems, and not just refractory hypertension, but multiple other problems as well. So again, talk to your doctor if you have daytime somnolence, if you're sleepy during the day, if you find you fall asleep as soon as you sit in a chair at night, you find you're falling asleep in the car, you're falling asleep during meetings, and if you are overweight, again, you're more prone to it. But again, I would strongly encourage people to pursue a workup if there's any question, because it's, again, immensely treatable. Again, we have good treatment for high cholesterol. Again, much more aggressive control of diabetes than we've sought in the past. We're trying to identify all the pre-diabetics to prevent them from becoming diabetics, or at least delay that. And again, we know that most patients with type 2 diabetes, at least 50 to 80%, will also have concomitant hypertension. Caffeine, it's variable, and I'm probably not going to get into that. Smoking, I don't think I need to talk about. Everybody knows that's not good. Stress really contributes to obesity. A lot of us are stress eaters, myself included, and working from home is a problem. Like, again, for me as well. You're sitting there all day, you're not exercising, you're not even walking around like you would going into the building or at work. The refrigerator's right there, you're under stress during the day, and you find yourself eating. And since I started working at home during COVID, I gained a lot of weight during COVID. And I think that's true for a lot of people. And you have to start really thinking about stress eating. What can you do for stress? Tai Chi, yoga, breathing exercise, meditation. But first acknowledging that you have stress and then really looking into constructive ways to control it. One that's never talked about is socioeconomic status and psychosocial stress. Housing, food, money, being able to pay your bills. These are all immensely stressful things that, again, contribute to hypertension and obesity. Similarly, it's wonderful for me to sit here and talk about all the healthy foods you should be eating. But if you're living in a food desert where there's no grocery stores, or if you don't have the money for healthy food, which is expensive, or you don't have the money, again, it's cheaper to buy processed food that, again, tends to be high in salt and high in other things you just don't want in your diet. That all has to be considered. We often talk about the 10-year cardiovascular risk. What is your risk to have a major cardiovascular event in the next 10 years? I want to make everybody aware that there's a calculator, there's an app, there's always an app. It's called the Prevent, PREVENT, online calculator. And it will ask you all kinds of things. It'll ask you your sex, your age, weight, height, or just BMI. It'll ask you for your cholesterol values. It'll ask you for urine albumin to creatinine ratio, which obviously you're not going to know off the top of your head, but if you've had a physical exam, it'll be in your routine labs. And again, that's an indication of kidney failure. But one of the things that it brings in that I've never seen any of these apps bring in, it actually asks your zip code. Because again, we know that in certain zip codes, the psychosocial aspects are huge. And, they can be food deserts where there's no grocery stores, very high incidence of poverty. And again, that has to be included in somebody's 10-year risk. But I would encourage everybody to think about just getting on the app sometime and looking at your 10-year risk. And again, your doctor will have all the values in there. Nobody expects you to know them off the top of your head, but they're all included in a routine physical exam and labs that go with a routine physical exam, including diabetic screening like the hemoglobin A1C. Next slide. When you're diagnosed with hypertension, they will get routine labs. And again, the labs are listed on the right. I don't want to dwell on this, but this should be part of a normal workup for hypertension. We again want to look at your cholesterol because that's going to contribute to cardiovascular disease as well. The serum creatinine and estimation of GFR we just sort of talked about. That's an estimation of your kidney function. Again, sodium, potassium, which we talked about, blood count. So again, these are electrocardiograms should again be part of it. People with thick heart walls and longstanding hypertension will often have EKG changes, but just be expecting this as part of the routine evaluation for hypertension. Next slide. Let's talk about medications. And we'll talk a little bit more in detail about when do you start medications. Now, some of this may, as I said before, 130 over 80 is a cutoff. Everybody with sustained pressures, 130 over 80 need to be treated. However, if you're in that range, but your 10-year cardiovascular risk is less than 7.5%, they advocate 3 to 6 month trial on aggressive lifestyle modification. That's exercise and diet. But again, if there's no improvement after the 3 to 6 months, then you need to be on medication. And again, that's a change from the previous guidelines, which left that more open-ended. And again, high-risk people that already have cardiovascular disease, people that already have chronic kidney disease, people that already have diabetes, again, will be more aggressive, and those medications may be started earlier than they would be in someone that has no other associated illness. Next slide. So let's look at the different stages. So stage 1, and again, we talked about that as 130 to 139 systolic, 80 to 89 diastolic. In most of those patients, you'll probably start with one medication, and that could be a thiazide diuretic, very often be either an ACE inhibitor or what we call an angiotensin receptor blocker, or ARB, and in some cases could be a calcium blocker. But often there will be an attempt to use a first-line agent. If you go to the next stage, now we're over 140 systolic and over 90 diastolic. In this case, the current new guidelines actually suggest starting 2 drugs, not starting one, bringing it to the maximum dose, and then starting a second one, which is the way we used to do it. Now, people are advocating using 2 drugs at a time to start, with a lower dose of both rather than raising one to the maximum before you start a second drug. And there's two benefits to that. One is you have a lower dose of both the drugs than you would alone, and so fewer side effects. Number two, you have two drugs that are working in different areas. And so you have a much better chance of controlling the blood pressure than just going with the one drug. Now, compliance ends up being an issue with medications in general, so we're always trying to ease compliance. So we're advocating two drugs, but we're advocating two drugs in one pill. And that one pill, those two doses in different pills, you can adjust those doses together. But it's still two doses, one pill. And we're always trying to use drugs that can be given either twice a day or once a day, but not multiple times a day like we used to do with some of the older drugs. Also, one thing that should never happen, which I still see happening occasionally, is people combining the use of an angiotensin converting enzyme inhibitor, a drug like captopril, monopril, anything ending in a pril, or one of the angiotensin receptor blockers. And those are things like losartan, olmesartan, things that end in tan like that. Those should never be used in combination. Next slide. So self-monitoring is a big part of all this, and it's important to learn how to use a blood pressure machine. I would also encourage you to check your pressure multiple times a day. The pressures vary significantly, and interestingly, your morning pressure tends to be your highest, because what ends up happening is you've been asleep the whole night, you wake up, and you get this adrenaline surge when you first wake up, and that can cause higher pressures in the morning. And interestingly, there's a slightly higher incidence of heart attacks in the morning, probably for the same reason. Next slide. We're going to go over how do you check your blood pressure, and it's important to use a cuff that's appropriate for you. Some people that are very, very thin need a smaller cuff. Some people that are heavier end up needing a larger cuff. And on the cuffs, there tend to be lines where you kind of line up the Velcro. If you're outside those lines, you probably need a bigger cuff or a smaller cuff. They might not be in the shelf at Walmart's or various places where you can go to get blood pressure machines, but they are available. You can get one, you can order one, or they may have one in the back. But the blood pressure cuff itself, if it's not the right size, you're going to get erroneous readings. And I think we'll go into a tape now, kind of talking about how do you check your blood pressure.
Okay, let's have a real talk about blood pressure. Do you monitor yours regularly? It's something everyone with high blood pressure should do, but it's something most people don't know how to do correctly. Checking your blood pressure regularly will help let you know if you have it under control. It will also help you start to understand which factors are putting you at high risk for stroke and heart attack. Before I get to that though, I just want to stress one thing. If you have high blood pressure, you should talk to your doctor to figure out how frequently you should be checking it at home. For most people, taking your blood pressure twice in the morning and twice in the evening, even just for a week, will help you and your doctor get a better understanding of your blood pressure. For morning readings, it's best to take those before you take your blood pressure medication. It's also very important to avoid exercise, caffeine, or tobacco at least 30 minutes prior to testing, since those can affect your levels. Now, let's move on to talk about the proper way to measure your blood pressure at home. Nearly half adults in the U.S. have high blood pressure and are at high risk for stroke and heart attack. So self-measuring is one of the easiest ways to be proactive about our health. Here I have my blood pressure monitoring device. It's easy to use and it helps me get an accurate reading. Be sure to get an automated device with the upper arm cuff. That's the type doctors recommend. The first thing you want to do is find a quiet place to sit where your back is in an upright, stable position. A dining room chair is great. You want to make sure the chair isn't too soft so your body is fully supported. Sit with your feet flat on the floor and don't cross your legs or ankles. If you need to use the bathroom, make sure you go before you do your reading. Next, rest your arm on a flat surface with your palm facing up. Place the blood pressure cuff on your bare upper arm just above your elbow. Your arm should be relaxed and resting so the cuff is at the same height as your heart. Now rest quietly for 5 minutes before taking the first measurement. Avoid talking while taking your blood pressure measurement. Once your first measurement is completed, write down the blood pressure numbers and pulse that are displayed on the device. Wait 1 minute and then repeat this process again. As you just saw, it's important to check your two measurements at around the same time each morning and evening. At your next doctor's visit, be sure to share your blood pressure numbers so you can discuss the numbers and so your care plan can be changed if necessary. That's it. Not bad, right? Measuring your blood pressure at home is easy to do and a great way to stay on top of your health. If you have more questions about managing or measuring your blood pressure overall, visit the website.
That was a great discussion. I'm just going to kind of go over a few key points. One thing I do want to mention too, we talked about BMI, body mass index, and over 30 is considered obese, and over 35 is considered morbidly obese. And I just need people to understand, if you see that in a doctor's note and somebody describes you as being morbidly obese, it's a medical term. It's not personal. They're not being judgmental. When you get over a certain BMI, 35 is a significant cutoff. And also, we've been measuring BMI and focusing on BMI. One of the things that's coming up now more often is looking at waist circumference. And you're going to see more and more of that in the future. I think it's an important variable, as important as BMI. And so, again, you may have your doctor checking your waist circumference all of a sudden. But that's, again, that's coming out in the literature more and more. So let's talk just briefly, just to review, how do you check your blood pressure? And again, as a simple recap, you need the appropriate cuff size. It should be on a bare arm. Make sure your arm is supported at heart level on a table or chair. Keep your legs uncrossed. Be sure your back's supported, that you're comfortable in a chair. Refrain from conversation. And one thing that's not mentioned here is sitting quietly for a few minutes. Don't just plop in the chair and do your blood pressure. You should sit in the pressure for 3 or 4 minutes and kind of relax before you do it. Also, if your initial pressure is high and you're stressed, sit for a few minutes, try to relax and see if that comes down. You don't necessarily want to treat or react just to an isolated reading that's elevated. And I think that's about it. I think if you can, I think it's great to have a blood pressure machine at home. Once you have hypertension, you're being treated, I think it's really important. And a lot of times we can get cuffs for patients and members free of charge or at a greatly reduced rate in many situations. But I think being an active participant is really important. Sharing your readings with your provider really helps decide when to treat, what to treat with, and when to treat. Like if your pressures are real high in the morning, you might want to give an evening dose. If they're real high in the evening, the morning dose may be more important. But you can write them down in a log. And a lot of these blood pressure machines now they'll attach to your internet, and you can actually send the results to your provider electronically. Also, a lot of them now pair with your Apple Watch. And again, you can collect them on your Apple Watch and download them to your provider. But starting to really keep a log and get a feeling of when your pressures are high and maybe things that trigger high pressures, and are you really under adequate control on medication, it's very helpful to have blood pressure logs. Thank you for your time today.
A big thank you, Dr. Copeland. Absolutely wonderful job. Now, I've been on the board for some time, and yet there was information you gave me today that was really helpful. And so we give a big appreciation on behalf of the board and everyone who listened today. As you see, I got an Apple Watch on. I'm in a walking challenge now to make sure that my heart rate's staying where it needs to be, and I'm super healthy and exercising and monitoring my blood pressure as I'm doing that. So thank you, Dr. Copeland. As you know, we're going to ask some questions in the chat. And here's the question from you. This is from the video. So what are some of the things that can impact the accuracy of your blood pressure reading? Drop that in the chat. What are some things that can impact the accuracy of your blood pressure reading? I think Dr. Copeland actually gave us, reiterated some of those things when he came back from the video. And so you can use the video or you can use what he said. I see what you're saying, your physical posture, caffeine, legs crossed, stress. That's a big one. Talking. Lauren Story said talking is a big one. For those who haven't wrote in the chat, here are some things. Again, talking while taking your reading, your legs crossed, drinking caffeine, that soda, that black coffee, doing exercise, using tobacco within the last 30 minutes, standing, cuff over clothing, right? It should be directly on the arm, as Dr. Copeland mentioned. Your back is not supported. Lauren also said the wrong size cuff. That's absolutely critical. Your arm not being supported on something and then sitting and relaxing. And so there are multiplicity of things that impact your reading, the accuracy of your blood pressure reading, but it's still important that you have the reading taken so that you know exactly where you are. Super important. And then here we have some great resources for you that you can take along your journey. You can assess your risk factors and get your heart score by going to www.mylifecheck.org. You can learn more about monitoring and managing your blood pressure by going to manageyourbp.org. So mylifecheck.org, manageyourbp.org. Learn more about high blood pressure, heart disease, and stroke at loweryourhbp.org. And then you can learn easy steps you can take to live a healthier lifestyle at the Life's Essential age. So many resources that are available to us as a community, from us as a board, from us as an association, an organization. Of course, Dr. Copeland gave us wonderful tips and tricks that we should know about the way. And so now, over the next few minutes, we'll review guidance to help you plan and implement the Blood Pressure Awareness Challenge activity. The goal is to raise awareness, with as many people as possible. And it's simple steps that you can take. So use the blood pressure awareness challenge checklist, right? Use the checklist to track your progress as you complete the blood pressure awareness challenge, and be sure to notify your company leader once you have completed the list of activities so that your impact can be tracked, and what we always like to do, celebrate it. Here's some steps that you can take. Step one, commit 30 minutes to learning about blood pressure. And guess what? You've done that. You're done today. Step one is all done. You've listened to me, but most of all, you've listened to Dr. Copeland give you wonderful information. Step two is to find openly accessible locations in your neighborhood where anyone can get their blood pressure checked. All right. So think about pharmacies, think about grocery stores, think about libraries, different places where you can just go in and get your blood pressure checked. And this key is absolutely critical. It's a key step in sharing this information with others. So you go and the blood pressure's a little high, make sure you tell and inform those who need to be informed. Step three, commit to getting in a routine. Commit to getting in a routine where you frequently check your own blood pressure. It's super important that you do that. You want to be counted as someone who knows their numbers and gets their own blood pressure checked. Step four, challenge at least 10 personal contacts, your family, your friends, your coworkers, to know their numbers. It's simple. Just know your numbers. Go to the grocery store, slide your arm in that machine, and get the reading. Make a appointment with your primary physician so that you can know what you're reading, or learn to do it yourself. And you want to track at least 2 blood pressure readings over a 2-week period. Absolutely critical and important. All right. And then the other ways that you can get involved is to join the American Heart Association's advocacy network called Heart Powered. We all have the power, all of us, each and every one of you have the power to make a difference by speaking out for policies that help build healthier communities and healthier lives. And you can join Heart Powered and be the first to know about the policies that are coming down, or the initiatives that are going to get passed, by texting HEART, 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 to 46839. And you can do that to join today. I want to take a moment to thank our sponsors for making today possible. Of course, deep appreciation and thanks to CDPHP. And again, big appreciation and thanks to Dr. Copeland for this life-saving information that was shared today. Also, thank you to CDTA, BBL Companies, Hometown Healthcare, and St. Peter's Health Partners for all that you do every single day to help us spread awareness throughout our communities. With that, I think the time is now 12:45, and I want to make sure that I'm doing what I need to do to make sure I can land the plane. I'm going to break the rules just a little bit and take one question. If there's one question in the chat, someone has already put the question in the chat. There's some questions that have come through that we can answer at a later time, but I'm going to ask this one question. Dr. Coplin, do you recommend, here's the question, do you recommend GLP-1s for people with HTN and obesity?
There was one
There
question
was
I
one,
hope
and that was
nobody
the
would bring
one.
up, and that was the one. GLP-1s are a very, very complicated discussion. Do I believe GLP-1s are a great class of medicine for the right people? Absolutely. When you look at the cost of the GLP-1s versus benefit, I think you really do have to be careful. It's not an easy solution. It's not a magic bullet. I still strongly believe in exercise and lifestyle modification for anyone that's going to be on a GLP-1. And that's what we require. And most insurance companies require that now. We'll cover it in the right situation, but we have to meet in the middle, and there has to be exercise and there has to be lifestyle modification. And part of that is on GLP-1s, some of the weight you lose is muscle mass. And muscles are what really determine how many calories you consume a day. So as you lose muscle mass, you are also decreasing your caloric need per day. So when you come off of the GLP-1s, not only do you go back to where you were, but you go even higher because you've lost muscle mass. Losing muscle mass also has consequences in terms of falls, and the injuries that go with falls. There's a lot of other side effects of GLP-1s. If you look at everybody that starts a GLP-1, only 50% of people are still on it at the end of 6 months to a year. They're making it less expensive if you go directly to the producer. I have issues with that. I don't understand how they can charge an individual $400 if they're charging the insurance company $1,200 per month, and also how they charge anybody those fees when in Europe and Japan and other countries they're paying $75, $100. This is a very complicated situation. Also, if you look at the benefits of GLP-1 and obesity and hypertension, it's generally not like a BMI of 30. You have to have a BMI over 35 to 40 to really see those benefits. Now, if you have existing cardiac disease, that's a different story. We're going to be very aggressive with GLP-1s, and we'll start those early. Again, if you have diabetes, you can make a good argument, again, to be on the GLP-1s for the diabetes. That will also provide significant benefit in terms of the obesity. Now, do I think they're a great class of drug? Yeah, but used rightly, used correctly, it's a much more detailed conversation. We could do an hour talk just on the GLP-1s and indications. But if you're asking me, do I think they're a good class of drugs? Yes, but again, used appropriately and used under the guidance of a physician. Being able to go directly to a pharmaceutical company and buy them directly from the pharmaceutical company makes me a little bit nervous. And again, there's a lot of bigger issues with the GLP-1s, and we're going to see better GLP-1s. There's going to be GLP-1s that act on 3 receptors rather than 2. And again, the pills just started coming out. Not quite as effective as the injections, but probably fewer side effects. But there's a lot of downside to GLP-1s as well. It's not all, and that's why, as I say, at the end of 6 months to a year, 50% of people have stopped the GLP-1s.
Well, thank you for that response, and I'm hoping, Emily, that you got the answer that you needed. I know that there are a ton of other questions that have come through. So first, I want to say thank you to everyone who joined us today. And if you have additional questions or would like more information, please visit heart.org, or you can reach out to your contacts at CDPHP or the American Heart Association. We'd be happy to help. As always, we appreciate all of your thoughts, all of your questions, and most of all, we appreciate your participation and your advocacy on helping us get to healthier communities, healthy neighborhoods, healthier lives. Dr. Coplin, again, thank you so much for your time today, and for everyone who joined our presentation, thank you, and have an absolutely wonderful day.